Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hi, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where we feature leaders in healthcare. This episode is brought to you by Arizona Hearing Center. I help patients to effectively treat their hearing loss so they can remain independent and be better socially connected. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. I lost him first to the hearing loss that he developed in his 20s from radiation to his brain tumor, and then subsequently from complications from that. I am the E of ENT. I only do ears. I've performed over 10,000 ear surgeries, and I take care of people with hearing loss all the time. I'm excited for us to talk about this today. If you want to learn anything more about my clinical practice, go to www.azhear.com, or you can learn more about my book, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss at www.listenuphearing.com. I'm really excited today. We have an excellent guest today. We have Dr. Jason Galster. He is a PhD in audiology and electrical engineering. He got his undergraduate degree and his master's from Purdue. He got his PhD from Vanderbilt. We're going to talk about that. And he is now the Director of Clinical Research at Advanced Bionics. We're really excited to have him here. Thank you for being on this show today.
And thank you for having me, Dr. Sims. It's a pleasure to be here.
Mark is great. So it's good.
Perfect.
So tell me about your journey to audiology and hearing science. How'd you get there? I told you mine. I had a brother with hearing loss. How'd you get there?
Yeah, thank you for asking the question. For me, it's been a lifelong journey. I had, even when I was a teenager, I got my first car, and I was one of those obnoxious 16-year-olds driving down the street with a car that you could hear before you could see it. And this was because I was installing car stereos in the trunk of my car and my friends' cars. And even when I was 16, I realized acoustics were interesting. And unfortunately, today I still have some ringing in this ear to credit to that hobby. So I don't advise it, but you do silly things when you're a teenager. But that really developed my interest in acoustics. I realized you could build a box and you could have a speaker in that box, and just by drilling holes in it or changing your port, you could really change the way the sound quality. You could change the sound quality. So I went into college with this interest in sound and found initially acoustical engineering, which as a career path ultimately didn't feel that exciting because I knew I would be designing boxes for the rest of my life for various acoustic purposes. And I've really enjoyed working with people. I always enjoyed working with people. And I was looking for a career path that involved people. And in some way, acoustics and audiology, interestingly, meshes those two things perfectly. So when I discovered audiology as an undergrad, it was like flipping a light switch for me. And I saw this path. And since then, I've known exactly the direction I wanted to go and exactly what my mission was. And so really that led me straight into audiology with a technical interest, a research interest, and a clinical interest. And so if you start there, it made a lot of sense how I found my way to audiology, but also how I really stayed with a technical lean, with an interest in research. So even though I've spent some time in the clinic to sort of hone those skills and understand the environment, I've always had a technical focus and a research focus. It took me from my undergrad to my graduate experience, then to pediatric audiology for a period of time. And then to my PhD program at Vanderbilt. And after an excellent experience at Vanderbilt, where I learned a great deal from wonderful people, I then went on to begin my life in technology development. And so I worked with Staey Hearing Technologies for about a decade, developing new-to-world hearing aid technology and extending my time researching hearing aids for about 20 years total, looking all the way back into my academic life. And then about 3 years ago, I started to realize that, and I loved working with hearing aids. I still love working with hearing aids, and hearing loss is a big driver for me, helping to treat it. But I realized about about 3 years ago that I wanted to broaden my horizon while still focusing on this passion. And that really helped me pivot a bit, find my way into cochlear implants. And so for the last 3 years, I've been working in cochlear implant technology development, which that really is my first introduction to the world of surgical intervention and all of the really interesting topics that come along for that, but an entire new realm of technology development and research. And today I have responsibility for clinical trials of new technology across the United States and North America, responsibility for clinical research around the world, and new technology development as well. So I'm getting to see some of these earliest clinical outcomes as soon as we begin to think and realize the feasibility of something new.
Well, that's great. I mean, what I say is I'm a clinician who's trying to catch up and learn more about audiology and acoustics. Not that I don't totally understand it, but there's always concepts that are for me to learn more. So that's really great. And for the listeners here, one of the things is the outside part of a cochlear implant is oftentimes a modified hearing aid platform. In other words, using a lot of the technology and hearing aids are used in cochlear implantation. And in particular, for the company that Jason works for, Advanced Bionics, its parent company is a hearing aid organization. So they have a lot of sharing of technologies because they can use the developments in other parts of their company for the overall organization within Advanced Bionics. So that's kind of a really cool thing. Well, my second question was going to be, how did you get into cochlear implants? But you actually already answered it. So that's really great. Tell me, one of the things we were talking about in the warm up was you're also involved in creating standards. That's another one of your passions. So tell me a little about how you got there and what you're working on.
Absolutely. So I mentioned that that I had this short stint as a pediatric audiologist, and when I went into my PhD program, which would have been the mid to late, before I was going to say mid to late 2000s, if that makes sense.
Yes.
But I was really focused on classroom acoustics for my dissertation. And as soon as I started my career, I got involved in a guidelines development group for a standard on pediatric amplification, basically a standard that says this is how you should prescribe hearing aids to children. And what I found in that effort was that it was really interesting to see how these global experts on a topic could get in a room together and disagree so passionately. And at the end of the day, through that disagreement, you came out, you really reached to the end of that process with this stronger understanding of the fundamentals, what it means to prescribe a hearing aid to a child. And so that was pretty early in my professional career. And I realized that experience was a huge growth opportunity. And for me, I learned so much from the other experts in that room and in that discussion. But what I've seen since then, because that standard was released, I think in maybe 2012 or so, I've seen the worldwide impact that it has had on the practice of pediatric audiology and how hearing aids are prescribed to children. And it's been so influential and so guiding that that it has been a motivator to me and to many other people to say, wow, we can do this. Now, there was already an adult standard, but there are many other ways that we can look to standardize practice in audiology and some of our adjacent professions as well. So today we have standards groups that function at a country level, at a global level. Some of them are with national academies. Some of them are independent. Some of them are related to organizations. You yourself had mentioned that you have some guidelines that are specific to your practice, which is excellent. I wish I heard that more often. But ultimately, doing any work that you can to drive a common understanding of what the standard of clinical practice should be is tremendously influential, and that's within audiology or anything else. So that's been a big part of what has motivated me to contribute to this. And today we're seeing new standards in cochlear implantation and how we audiologically prescribe the cochlear implant. We're seeing new standards in pediatric amplification, adult amplification. We have standards in how assistive technology is fit as well. So there's a great amount of work going on in this area, and I'm excited to see it develop.
Yeah, I find it does two things. One is obviously it does create a clinical standard, but the other thing is what it also does is it makes you really define terms that we all use that we don't necessarily all, when we use a term, we're all not necessarily speaking about the exact same thing when we use that term. So things enter into our practice or our literature or whatever you want to, into our fields that aren't always defined where people are actually talking about the same thing. So it's pretty hard to do research and move the field forward if we're all using a word or terms that don't mean the same thing to everybody. And so I think that's another great thing. And I'm sure that's probably a part of what you experienced when you were working on these guidelines was that the vocabulary is the commonality, the first thing you have to come by. It's an interesting process.
Absolutely. Coming to that common language isn't always an easy thing.
Right.
But it's part of every one of these standards. And you can see these terms sort of feed forward and show up in other publications and books like the ones you've written. But it's hugely beneficial. But if we also think about access to technology and reimbursement,
to standardize the care, to talk to reimbursement and insurers, right? If you're again, they'll just say, well, we don't know what this means, so we're not going to cover it. I mean, that's kind of and to get good clinical outcomes, again, you have to have the same definition of the clinical entity which you're trying to change.
Mm-hmm. Yeah, so, you're exactly right. I think there's actually an unfortunate example recently where the National Academies of Science, I'm not sure if you saw the press releases about this, but the National Academies of Science looked at the existing evidence for screening of adult hearing loss.
Oh, yeah. To bring it into the annual examination. And they said there wasn't enough evidence. which, like, from a clinician point of view, you're like, really? It's hard to believe that.
You and tens of thousands of other people around the world saw that and said, how could they possibly arrive at that conclusion? But when you go into the literature and you look at the truly high impact peer reviewed evidence, it's understandable how the expert panel arrived at that conclusion to not recommend hearing as a part of, or hearing screening specifically as a part of every annual medical evaluation starting, I think it was at about 50 years of age. There's a recommendation to do this later in life, but not quite that young. But when you do look at the evidence, it's understandable how they arrived at that conclusion. And I'm happy to say that conclusion at the level of the National Academy is going to motivate a tremendous amount of research in this area, and we will see the evidence develop. But it's a really good example and a pointed one in recent time, where if we had standards and guidelines earlier that were substantiated by the evidence, we wouldn't be in the same position today.
Yeah, unfortunately, sometimes belts and suspenders kind of research is not as interesting to people as well, right? And so that's kind of, really foundational work that I think is highly impactful, but maybe not as flashy as some people want their research to be. But that's great, because sometimes you need kind of a little bit of splat, a glass of cold water thrown in your face to get you to understand that it's important. So you're in the cochlear implant world and you're doing clinical research. So, just to look at speculation, which is always fun, where do you see cochlear implants or the field 5, 10, and 25 years from now, right? So it's like, what are the, upcoming the changes and developments? What are the longer, midterm, and then long-term developments? Where do you see things going?
Yeah, absolutely. To look to the future, I think it helps to pull some context in from the past. And if we stop and we think about cochlear implants and the history of cochlear implants, it's a technology that's only been around now for about 30 years. And is that
really
right?
Mainstream for 20.
Yeah, exactly. So we start to think about mainstream technology with the current, let's say patient population for about 20 years. And if we look at this time period going from will it work 30 years ago to, oh my gosh, yes, it works. And it starts to work at a really large scale, in this 20-year time frame. If we look back at that history to where we are today, what's fascinating is that the consistency and the quality of outcomes that we see in patients today is really amazing. And as I mentioned at the beginning, I came from such a long history in hearing aids that admittedly, and shame on me a bit, but admittedly, I didn't have a really clear view to cochlear implant outcomes when I was focused all day, every day on hearing aids. And what has been really illuminating to me over these last 3 years is just the quality and again, the consistency of outcomes with the cochlear implant patient and how many people there are who are getting by quite well with hearing aids, but truly their outcomes could go to another level and their quality of life could even really improve substantially if they considered cochlear implantation as a treatment as well. And so when I look backwards to today, how we've sort of taken that variability of patient outcomes and brought it into this range of pretty high quality, I think is what impresses me the most. And audiologically, what has surprised me as I've gotten really close to it. Now, when I look forward to 5, 15, 20 years, there's no doubt that I expect the consistency of outcomes to continue to get better, and for that window of variability to continue to shrink in a positive way.
So better prediction of consistent outcomes, correct?
That's exactly right. And I hope that within, say, the next 5 years or so, we'll be doing a much better job at looking at an individual patient, their demographics, their audiologic information, and being able to say, this is how well we think you're going to do, make a prediction of how well they're going to do after they have that cochlear implant. And that's something that's been a real challenge leading up to today, even though there's been a lot of research in that area. So I think
I think one of the challenges in that particular space, if I can comment, is audiologic versus subjective satisfaction, right? Mm-hmm. And so, having done this long enough, there are people who have incredibly excellent audiologic outcomes who are dissatisfied, and people who have rather mediocre or borderline poor outcomes who are incredibly satisfied. And so that psychosocial component is actually another thing that we probably have to go deeper into, is to measure people's not audiologic outcomes, but their satisfaction with the audiologic outcomes. And that unfortunately is a little more fuzzy, but it's actually where we really have to go. And especially I think with payers, talking about insurance and reimbursement, I think that becomes very important. But I'm sorry to interject there, but I think that's really important.
No, you're exactly right. And I think that's specifically one of the areas where we'll get better at considering that in counseling people and predicting their global, satisfaction. And quality of life is one way of describing a lot of those subjective components.
It's a big bucket.
Yeah, exactly. So I see that element, which I think will have really clear clinical value. I see that getting better. If we sort of drill down to the tech topics, which are a lot of fun to talk about, we sort of have to break these out into this outside piece that looks like the hearing aid, what we call the sound processor. Right. And then we have the internal component like the electrode. And so when you look at the internal piece, that surgical piece, there's a very clear path that the electrode, the piece that goes into your hearing organ, the cochlea, that is going to get smaller and smaller, that it's going to get easier to put into the cochlea. And that's what we would describe as less traumatic, right. Which means that when you're able to put something in the cochlea and you cause the cochlea less trauma, that means that all of the structures within that cochlea that help you hear, even when you have hearing loss, you tend to have some hearing left over, that residual hearing. We do expect these electrodes to get progressively less traumatic, do a better job at keeping those structures in place, and then also preserving that hearing that people went into the surgical, into the surgery with.
Right.
And we know from years of research that a cochlear implant patient who has some leftover acoustic hearing, we know that they'll tend to do better in their outcomes, better speech recognition, better satisfaction. And in some cases, they'll have an opportunity to listen both electrically and acoustically on the same ear.
Yeah, no, that's great. And so that might be 5 years still, or are we looking at 10 years?
We'll see consistent steps in that progression. So we'll definitely see steps within the 5-year time frame that will help. Yeah, that will help to be less atraumatic at the time of insertion. We'll also see steps, and we're even taking steps today that can help provide feedback during the surgery related to how you're interacting with the structures of the cochlea, so we can measure the response of the cochlea during the surgery.
Sure.
And we can actually say if the response is decreasing in terms of hearing ability. And so all of these things will very likely help to improve surgical technique. And then the advances in technology will also help to improve the manner in which the electrode sits in the cochlea. And hopefully that will be less atraumatic. So we have better outcomes because of that. If we continue to look in the future, we'll see combination devices where there's a drug treatment that's applied to the electrode. That may help with healing. It may help reduce some of the initial trauma by easing the electrode insertion. And so if we follow that trajectory down the path, a lot of this comes back to easier electrode insertion,
right,
really a healthier placement of the electrode, and all of that nets better hearing outcomes just based on the electrode position in the ear.
And the outside part is as hearing aids continue to advance, obviously, cochlear implants will. So connectivity has really been a big thing because hearing aids have become more connected. So the cochlear implants are more connected. Where else do you see that going?
Yeah, so it's absolutely the case that hearing aid technology is going to drive a good portion of the cochlear implant technology from a sound processing perspective, that outside device in the future. The hearing aid companies move extremely quickly, and the cochlear implant companies get to benefit from those advancements. So what we'll see specifically is better leveraging when people are wearing a device on both ears, whether it's two cochlear implants or cochlear implant and a hearing aid. We're going to see this wireless technology, better processing noise, better processing speech to make speech more accessible. We're going to see better wireless connectivity to everything around us, including remote microphones that are really fantastic at picking up speech a long distance away.
How about a bicross? Is that coming?
And we'll also definitely continue to see advances in cross technology, where if someone can't hear on one ear, but they're implanted on this ear, we can beam that speech around the head, overcome the head shadow effect. That will definitely be on the horizon and has existed previously. But we shouldn't overlook the fact that the electrical cochlear implant technologies are going to advance as well. So there's an entire opportunity as we look in this 5 and 10 year time frame to leverage technologies related to artificial intelligence and machine learning to make what we call coding strategy, which is how we electrically stimulate the cochlea. We're absolutely seeing opportunities to make these coding strategies better by advancing the technology, leveraging machine learning techniques, leveraging artificial intelligence. We can also use those same techniques to work on denoising speech so that when it reaches that electrical coding stage, that the speech is better preserved, that it's cleaner. And then the coding strategy, of course, is more effective because it's operating on a nice, clean, intact speech signal. But we do see ways to make coding strategies lower power, really extend the battery life without increasing battery size. But also just making sound, continuing to drive sound quality forward, continuing to drive speech understanding and sound access forward as well.
Yeah, I always tell patients they should thank God for cell phone technology because, boy, the cell phone technology has pushed all of this stuff, battery life, miniaturization, all of that stuff. I mean, not that the hearing aid and cochlear implant world don't want to, but it's really that direct-to-consumer large market that's driven a lot of these innovations. So how about a totally implantable? Everybody always asks me that. Where do you see that? Totally implantable cochlear implant without an external part.
Yeah, I believe that we will most certainly see cochlear or fully implantable cochlear implant systems where there'll be nothing worn on the outside of the head. There are a great deal of hurdles that need to be overcome to get there. You need to understand where are you going to put a battery inside the body. And of course, there's precedent for placing batteries down here, and you'd have to think about running the battery lead up the neck to the cochlear implant system. So there are paths to do this. It's being explored. There's a lot of research and technology development going on in this area. So we'll definitely, in the future, see fully implantable cochlear implant systems. That said, there will very likely be trade-offs that are made related
performance or size or something, because the battery's larger, or reoperation to change the battery or something.
You're exactly right. It's very likely that the total surgical procedure will be a bit more complicated, which we would expect. And then there are some convenience trade-offs. So, for instance, you'd question whether or not you'd have any wireless connectivity for a fully implantable system. You'd question the nature of the microphone, where it's placed, and there'd be some limitations related to some of the helpful sound cleaning technologies we have with the external sound processor.
Or upgradability, right? So that's one of the beauties of the external processor is you can upgrade the whole electronics pack. Right?
Exactly. Just like these days, just like there's always a new cell phone on the horizon, there's a new sound processor on the horizon as well.
Yeah, that is so true. I mean, I just to contextualize myself, when I first started in cochlear implantation, there were only body processors. So I actually got into CI right when they were going above the ear. And boy, they were a lot bigger. I mean, I know patients will say to me, "Can't you get it smaller?" It's like, yeah, but it's pretty amazing how small it is already. So, I mean, I'm amazed how far it's come. So this is all great stuff. So, let me ask you a question, Jason. Like, in terms of, I say to people, like, say you're going to an awards banquet, you're getting a Lifetime Achievement Award. Who do you thank? Like, who are those people that you say, thank you for helping me get here, whoever that is for you?
Absolutely. There are a lot of people that I'd like to thank all the time, and I think it changes based on the day. Sometimes you'll thank one person, like your mom, if you just feel like you were raised well. So thank you, Mom. But professionally, I do have to recognize my mentor, Todd Ricketts. I owe him a lot for where I am today and who I am today. He and I first met when I was an undergrad, and so my entire professional career is really being mentored by him up until my technology career path in industry. I also have some folks who I learned a lot from. One is Ben Hornsby, also faculty at Vanderbilt. Ben taught me a lot about what speech means and how we can study speech as a signal, and understanding speech and communication is a fundamental thing when you think about developing a treatment for hearing loss.
Sure. What are you trying to hear? In other words, what is it that's really important?
Exactly. And if we go back to guidelines, a lot of the guidelines start with the primary goal of the treatment being access to speech, because it's our mode of communication. So it's an underpinning for everything we do. And anytime I'm talking about anything related to hearing loss, I'm always thinking about speech and communication access in the background. And then I also have to recognize Wes Grantham, who is a psychoacoustician. And Wes worked in his career looking at spatial hearing. So basically, if this one sound is to your left and one sound is to your right, how do you localize to one sound or the other? And then even more challenging, if two people are talking at you and you have two overlapping voices, how
prioritize and pull them out, right?
Pull them up. Yeah. So the attention that you need to pay to a person is a fantastically interesting topic. And so what Wes taught me, and teaching has always been I've talked about a lot of passions. They all come back to hearing. But I've really enjoyed teaching, and I've always looked for that opportunity. And I still keep today 2 adjunct positions, and I teach a few courses a year. And what Wes taught me that has always been valuable is he taught me how to look at literature, look at the peer-reviewed literature, and then translate that into educational material.
Right. That's excellent.
And it's one of those things that I honestly, I don't know that would have ever been a fluid behavior for me.
No, that's definitely something through mentorship, I think, right?
Yeah. So all of these folks, I credit greatly. And then there are people who I've looked at as leaders like Catherine Palmer, who's been just a really clear voice for clinical practice in audiology. And so I have to credit her because she's the kind of person that you always hear her voice in audiology talking about driving the profession forward and making sure that we're coming together and growing. So I have to, even though she hasn't been directly mentoring me as a professor or teacher,
Right.
She's the kind of person that whether or not she knows it, I really look up to her as a mentor.
That's great. That's great stuff. Thank you, Jason. Last question. What's your favorite sound?
My favorite sound. It's definitely laughter. There's some videos that you watch online where you're not laughing and you don't know what someone's laughing at. But there's something that is human nature that when you're around somebody who's laughing or smiling or just has that exuding positivity, it's addictive. It's like catching a yawn from someone else. You can almost catch laughter. And so that's part of why I think it's such a phenomenal sound.
So it's interesting. I'm dating myself, but Paul Lynn, who used to be on Hollywood Squares, he used to get everybody laughing by laughing. And I will share with you, that is also when people ask me what my favorite sound is, I always say laughter as well. So you and I are simpatico in that respect. Well, Jason, this has been great. We've had Jason Galster. He's the Director of Clinical Research at Advanced Bionics. Jason, if people want to get a hold of you, how would they do that? The website, or what would they do?
I'm always available. My professional email is my name, jason.galster@advancedbionics.com.
All right, that's great. So if anybody has any questions or anything they want to follow up, go ahead and reach out to him. Jason, this has been great. Thank you so much for your time. I really appreciate you coming on the podcast today. This has been a really awesome conversation. Thank you so much.
Yeah, thank you, Mark. This was a pleasure. I appreciate it.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.